Hello Brain Shakers, welcome to the Brain Shakers Academy. Excited for yet another session on diabetes mellitus, and in this particular one we'll be looking at the pathophysiology of diabetes mellitus. What actually happens for us to end up having a big baby when we're looking at gestational diabetes mellitus or diabetes in pregnancy. So if we quickly dive into today's session and briefly look at some of those steps that actually happen to try and explain why we see those things, then that is going to be helpful in understanding what exactly we are seeing. So we already have a background understanding that the rise in the hormones there during pregnancy is what is going to bring about the insulin resistance or reducing the insulin sensitivity, meaning that there will be circulating glucose within the blood that is not being utilized by this body because you have a rise in those hormones that are stopping the insulin from doing its thing and getting that glucose to work. So the circulating glucose within the body is going to give us a state of maternal hyperglycemia. So we're going to have maternal hyperglycemia around here. This simply means that we are in a state of high sugar levels. So it means that you have high sugar levels, maternal hyperglycemia. Now, if you have maternal hyperglycemia, remember, we did make mention that if we do the glycated hemoglobin test and we find that the levels are above 86 millimoles, which is above 10%, or reaching 86 millimoles, it means that we are at a higher risk of impaired organogenesis. So this maternal hyperglycemia is then going to lead us into impaired organogenesis. So organogenesis is just basically the formation of the organs. It means that the process of embryology, the process of forming those body structures, those body organs, is going to be impaired because of too high sugar levels. And once we have impaired organogenesis, then we are going to end up with congenital malformation. So this then leads us to congenital malformations here. Okay, so once we have gotten to that level, then we'll end up into congenital malformations. Now, this maternal hyperglycemia here, it means that the glucose has the capacity to actually cross the placenta and then be transferred through to the fetus. So the fetus will also be in a state of fetal hyperglycemia. So that is then going to lead us into what we will call fetal hyperglycemia. So these are high sugar levels also in the baby. Now, with high sugar levels in the baby, this is going to reduce the amount of cortisol that is being produced. So this is going to bring about a reduction in cortisol. Okay? Now, cortisol is basically steroids, and you need the steroids for you to have a baby that has lungs that are well inflated. Because if you have a reduction in the amount of cortisol here, this then is going to bring about a reduction in the production of the surfactants. Okay, so the surfactant here that we're talking about is basically lecithin and sphingomyelin. Okay, now the surfactant is an important protein element that we need to get those lungs of the baby to be open, and then it will be easier then to aerate them. Now, if we have inadequate surfactant, then it means that this is going to then take us into a condition that we're going to call RDS, or respiratory distress syndrome. So we will end up with respiratory distress syndrome. Why? Because we don't have any adequate surfactant. Okay, now if we have fetal hyperglycemia here, this fetal hyperglycemia also is going to cause the signs and symptoms of high glucose levels. We know that there is polyuria in cases of high glucose levels. So the fetal hypoglycemia here is going to lead us into a situation where we are going to have osmotic diuresis. So here now, this takes us into fetal osmotic diuresis. So it means that this fetus is now passing plenty of urine in there. So there's polyuria. And then this fetal osmotic diuresis that we are seeing here is then going to then lead us into a state that we're going to call polyhydramnios. Okay? So we are going to then end up into polyhydramnios. Okay. And that is why babies that are born out of the gestational diabetes mellitus, they may come out with plenty of that fluid, and then once they are delivered, then you have to insert an NG tube just to make sure that everything else is adequately patterned. Now, we are still at fetal hyperglycemia here because of the maternal hyperglycemia. We ended up with fetal hyperglycemia. Now, the fetal hyperglycemia would then stimulate the fetus to produce high amounts of insulin. So we end up in a state that we're going to call fetal hyperinsulinemia. So it means that hyperinsulinemia, meaning that there is a high amounts of insulin circulating in the blood. Now, if there is amount of insulin that are in high levels, what is then this fetal hyperinsulinemia going to bring about? This fetal hyperinsulinemia is then going to bring about, number one, it is going to bring about an increase in the oxygen demand. So we have an increase here in the oxygen demand. Okay. When we have a higher oxygen demand here, it means that there is then going to be an end result of a reduction in the oxygen tension. Okay. Now, when we end up with a reduction in oxygen tension, this is then going to force the body of the fetus to then go into anaerobic metabolism. So we will end up with anaerobic metabolism here. Okay. Now, when we get to levels of anaerobic metabolism here, meaning that it is using other sources to actually break down and then produce the energy that it requires. And as it breaks down those other sources, the end result of this will be lactic acid. So once we then get to levels where we are producing adequate amounts of lactate, so we have high lactate levels here, then we have gone into a state that we will call acidemia. Okay? So the pH of blood now is in the acidic state. Now, acidemia is going to then lead into intrauterine fetal death, or you can end up with an abortion. So this can bring you into states of an abortion, or you end up with an intrauterine fetal death. And that is why a woman that has gestational diabetes or pre-existing diabetes, when they are in labor or when they are in their stages of pregnancy, they need to be constantly observed, because that can actually bring about an abortion or an intrauterine fetal death. Now, while as we are still on reduced oxygen tension, the reduction in oxygen tension then is going to bring about what we call compensatory erythropoiesis, meaning that the fetus begins to make further blood cells. It makes more red blood cells. So this then brings us to compensatory erythropoiesis. Okay. Now, Compensatory erythropoiesis is just an increase in the number of red blood cells that are made within the baby. Now, we know that the red blood cells, they contain hemoglobin within them. And after this baby now has then been born, so we'll say that if they produce more or adequate amounts of these red blood cells, then they will end up in a state that we call polycythemia. Okay, so meaning that they have more of these red blood cells. And when they have polycythemia, once the baby has been born, it will need to break down those red blood cells and reduce the hemoglobin level from fetal hemoglobin to adult hemoglobin. So the breakdown of those excess red blood cells then is going to produce unconjugated bilirubin. Now, unconjugated bilirubin is what will then take this baby into neonatal jaundice. So the end result of this now here is that this baby is going to end up with a neonatal jaundice. Okay, neonatal jaundice. Now, we come back again to fetal hyperinsulinemia. Now, when there's fetal hyperinsulinemia, it means you have more growth factors as well coming into play. So you have a higher amount here of insulin-like growth factors. Now, when you have higher amounts of these growth factors, it means that that glucose now is going to be picked up and then stored into shoulders, stored into the scapular blades, into different layers. And that means that now the shoulders become bigger. And that's why these ones that are born from gestational diabetic mothers, they may end up also with shoulder distortions. So the baby now becomes bigger because you have these growth factors that are on the higher side because of the fetal hyperinsulinemia that is coming as a result of the raise in the glucose levels. So if you have these growth factors now in high amounts, they get that glucose and store it into the fetal body. And then you end up now with a baby that is bigger. It means you end up with a macrosomic baby. So you end up with a macrosomic baby here. Okay? Or the fetus now is macrosomic. So if the baby is on the higher side, it means that delivery here are going to be, delivery complications here are going to be prominent. Number one, you'll be at risk of obstructed labors. Two, you also be at risk of operative deliveries. You also be at risk of complications such as a shoulder distortion. Now let's put one of those complications here as a shoulder distortion. Okay, so let's take, for instance, you end up with a shoulder distortion. When you end up with a shoulder distortion, then it means that there's going to be manipulation to try and deliver those shoulders. Now, as we try to deliver those shoulders, there can be injury to the brachial plexus. The brachial plexus is just a bunch of nerves that are emanating all the way from the back and coming to supply the hand. Now, as we deliver those huge shoulders, there will be injury to the brachial plexus. And if there is injury to the brachial plexus, then you end up with a baby that has birth injuries and also complications that we can call the Klumpke's palsy, or they may end up with what we can refer to as an Erb's palsy. Okay, so depending on which part or which level of that brachial plexus that has been injured, you may end up with a baby that basically has a palsy throughout their life. So basically that is what maternal hyperglycemia is going to do. It then brings out this vicious cycle that is then going to bring out all these problems if we have not managed the glucose levels and we have not managed to bring this woman into the normal levels. So we may end up with either congenital malformations within the first trimester, or if we go all the way until delivery, we may either end up with complications such as palsy, complications, respiratory distress, or end up with a neonatal jaundice. So basically, this is what happens during the state of high glucose levels in the mother. So the state of pregnancy has an effect on the disease itself, diabetes, because you may end up with complications such as retinopathies, you may end up with neuropathies, you may end up with nephropathies, and then the diabetes itself also has complications that affect the pregnancy itself, and these are some of the complications that we have talked about. So you are also at risk of developing other conditions such as hypertensive disorders. Why? Because then there is going to be alteration of how your placenta is going to embed and get into the decidua, and then you end up with hypertensive disorders. Now basically, this is about the pathophysiology of the diabetes in pregnancy, and this is what basically it does for it to give you all these complications that we have talked about. And I am hopeful that you enjoyed this session, which explains some of the effects of maternal hyperglycemia on the outcomes of either the baby or the outcomes for that particular pregnancy. And if you found this particular video helpful in understanding partly about the pathophysiology of diabetes mellitus in pregnancy, don't hesitate to give it a thumbs up, share the video as much as possible, and also subscribe to the YouTube channel. That is one of the ways that you can actually show support to what we do, and we will continue doing what we are doing. Remember to drop me comments in the comments section as well. Share the video as much as possible, and you also have an opportunity to join the membership team. Be a member of the Brain Shakers Academy so you can continue to enjoy the exclusive benefits of actually being a member. Thank you so much for watching, and I will see you in my next video.